So, warm welcome to Dr. Rajesh Ramachandran, my dear friend from India. So, good morning, all of you, and good evening, Dr. Rajesh. I think it is 11:30 p.m. there in Canada, is it not? And I'm very, very happy to welcome my dear friend, Dr. Rajesh, who had, we had a long association from 1994 onwards. And he did his MBBS from IAP Medical College, MD from SAT Trivandrum, then went to do the DM Neurology from Sri Chitra, and then a fellowship from Toronto, Sick Kids. Now he's a director of epilepsy services in McMaster University, as well as he's an associate professor there. And he was stopped. There was an incident where he was stopped at the immigration office in Canada, and they had stopped him because they found gold in his bags, and to their surprise, they found out it was not gold smuggled from India; it was gold medals. From he had all through his careers, he had bagged a lot of gold medals, even from MBBS days. He was first in the final year MBBS student, and he was first. I think he was SLC topper also. So he was one of the most brilliant student and an astute clinician, and it was really a pleasure to work with him when we were in SAT. And he had worked here in Calicut Medical College for some time in the Department of Neurology, and from here on only he had gone to Canada for doing the fellowship and then settled here. But still, he loves our country, and that's why he has shown great interest in improving the academics, as well as improving the knowledge in the field of pediatric neurology. And I still remember his one of the papers that we had co-authored in the Pyridoxine-dependent seizures in IP, which I was fortunate to be a co-author of. I don't know whether Dr. Rajesh remembers it. And so his interest in pediatric epilepsy, especially neonatal epilepsy, started even very many years back. So I welcome once again Dr. Rajesh, and welcome all the listeners here from various medical colleges. And I wish everyone a happy Doctor's Day. And I hope this will be fruitful to all of us. And over to Dr. Mohandas, who is the chair of this session. Dr. Mohandas is our additional professor, and he's in charge of neonatology in our institute. Dr. Mohandas.
Hello. Good evening, Dr. Rajesh. And good morning to all from Kerala. So we are privileged to have Dr. Rajesh, a dear friend of mine, to talk on a very important topic, neonatal seizures. So apart from the academic brilliance, Dr. Rajesh is much more than that. He could be our health secretary if his IAS dreams were fulfilled at that time. He loves music. He writes poems. Very good fan of old Malayalam songs. And welcome, Dr. Rajesh, to the topic neonatal seizures. So neonatal seizures is a very important problem in neonatal nursery. And at present, IMCH Calicut is part of a multicentric trial where we are trying to prevent epilepsy by reducing the burden of neonatal encephalopathy by implementing a care bundle during delivery. So we are all much interested to know the recent things about neonatal seizures. So I invite Rajesh to deliver the talk for the next 30-35 minutes, and we can have a discussion for next 10 minutes. Dr. Rajesh.
Rajesh, you can start sharing your screen. Rajesh.
Okay, can you see my screen right now?
Yeah.
Okay,
Yeah.
Thank you so much, Dr. Ajit and Dr. Mohandas, for this kind invite. While we wait, may I request the audience to go to the webpage polev.com. You can use your smartphone and just type in this in your web browser. When you do that, you see this page where you type in my username, that is Rajesh R100, and then click join. It's very simple. So this is where I work. So at the bottom, you can see the McMaster University campus. On the right top, this is McMaster Children's Hospital. On the left top, this is Hamilton City in the night. So let's start with a case. An infant boy born at 39 weeks via emergency cesarean section, secondary to placental abruption and fetal bradycardia, and the birth weight was 2.5. Infant was initially depressed with no respiratory effort, was flaccid, and heart rate was less than 100 and required intubation and resuscitation. And ABGAs were 1, 4, and 5, and the core pH was low with a base deficit of 23. Was transferred from the periphery to a center, which is a reasonably big size NICU with nearly 58 level 3 beds and about 20 level 2 beds. So that is reasonably big. The child was loaded with phenobarbital 20 milligram per kg twice, had ultrasound to rule out bleed. It showed maybe some mild cerebral edema. So if you could answer, just go to polev, Rajesh R, then type what would be your response. The baby has, after phenobarbital, intermittent lip smacking. Which are the following best, which one of the following best reflects your thinking? Baby who received therapeutic cooling seldom develop seizures, so I'm not concerned. I think lip smacking are seizures, so I will treat the clinical events. I'm not sure if lip smacking is seizure, but he is at very high risk of developing seizures. It doesn't matter. He needs continuous monitoring one way or the other. None of the above. You just type in A, B, C, or D. You don't have to please me because I am an epileptologist. Awesome. Very good. It keeps on changing. Thank you so much. Let us move on. So neonatal seizures is a very common emergency in the neonatal intensive care unit. It's quite challenging to detect neonatal seizures, and people always wonder, why are we doing this? Is the seizure really harmful to the brain? So let us see where we stand with regard to each of these incidents. So it's all over, but if you really look at good quality studies, I would put it as between 1 to 5. So let us stay around 3 per 1,000 term births. But if it is in a very low birth weight infant, most of which are premature, especially in the developing countries, it is quite high. So this one, a 2-day-old infant with seizures, eye deviation with nystagmus, with behavioral arrest, so they are seizures. Up to 7 per day, and EEG showed seizures coming from the occipital region. So type in, what is the etiology of his seizures? HIE, stroke, hypoglycemia, B6 dependency. Wow, it doesn't change. Brilliant. Okay, so this is the etiology of neonatal seizures. The major part, I would say around 40%, is due to hypoxic ischemic encephalopathy, followed by vascular lesions, stroke, either occlusive or hemorrhagic, followed by infections and brain malformation. And then you have all the weird and wonderful syndromes and metabolic genetic conditions. So the first MRI here is the hypoglycemia. You can see in the bilateral posterior head region, you have significant diffusion restriction, which is seen in white. Hypoglycemia predominantly affects the occipital region because that is the most metabolically active region. And here you can see a neonatal stroke. So this is the left side and this is the right side. So in the left posterior head region, you have an arterial stroke. Along with the theme of cerebral malformations, you can see this brain on the left side is completely abnormal and it is quite big, and the gyration pattern and sulcation is quite abnormal. So this side is big but abnormally big, and abnormal neurons, that is hemimegalencephaly. And this is a typical case of a near total HIE. You can see in bilateral basal ganglia diffusion restriction. And this is the MR venogram showing occlusion of the superior sagittal sinus as well as the deep venous system. So this is cerebral venous infarction, and this is intraventricular hemorrhage. So the detecting the neonatal seizures, well, before that, we need to understand what is a clinical seizure and what is a subclinical seizure. Are they really different pathophysiologically? So you have seen children getting EEG. So what is seen in red is a seizure. And what is seen in black dot is where we keep the electrodes over the scalp, not over the brain. So if you have a seizure near the motor cortex, what you see outside is a motor movement, maybe a clonic movement or a tonic-clonic movement. Look at the left side. You have the seizure coming from the anterior frontal region and bit from the anterior temporal region. So what clinical sign would you expect in a neonate? You expect only very minimal signs. They are unlikely to have a bilateral or a unilateral limb motor movement. Maybe there could be some automatisms. So, but if you look at the extent, this is a graphic representation. And for the brain, the neurophysiological implication is same. So the point I want to really drive is it doesn't matter whether it is a clinical seizure or a EEG seizure, the burden on the brain and the pathophysiological mechanisms are the same. So there is no point in saying I treat clinical seizures, but I don't treat electrographic seizures. The reason is what you see outside depends upon where the seizure happens. And are we really good in recognizing seizures? Well, this is a study from Ireland, which was published about 12 years back. So what they, could you kindly mute your mic, please? So the inclusion was at birth. If they fulfill two or more inclusion criteria, essentially it was suggestive of a perinatal asphyxia or clinical seizure developed. And all those patients had continuous video EEG monitoring for 24 to 72 hours. And at the same time, the bedside staff recorded all seizures in the chart, but they had no access to the video EEG recording or the video EEG report. So they just proceeded with their clinical observation. So what was the result? 41 neonates were recruited, out of which 11 had documented clinical seizures by the staff and 1 had electrographic seizure. So total of 12 infants. Well, total number of seizures recorded in those 12 patients over 24 to 72 hours was 524 by the EEG. So each EEG seizure is characterized by any recruiting rhythm lasting more than 10 seconds. So one seizure could be several minutes or up to 10 seconds. Well, Out of this 526, by carefully analyzing the video, only 34% had a clinical correlate, maybe a limb movement, maybe a chewing movement. That means majority of patients did not have any clinical correlate, though the EEG showed seizures. Well, out of the 175, which are clearly clinical and EEG seizures, the bedside staff recognized only 27%. So 527, 26 to start with, and only 48 were recognized by the staff by the bedside, that is less than 10%. And the nursing and medical staff recorded, without looking at the EEG and the video in their chart, 177 seizures and treated. When it was reviewed in the video EEG, more than 70% were actually not seizures. They had no EEG correlate. So what does it tell us? Majority of seizures are not picked up on clinical exam, and majority of the seizures which you deem as seizure based on your clinical expertise is not really seizure. So in summary, clinically silent seizures are very common, and all that shakes is not seizure. Okay, please have a look at this video. Hope you guys can see the video. I think that is enough. Okay. What is the clinical event? Okay, type in your answer. Just type in myoclonus, benign myoclonus, sleep myoclonus, seizures. Somebody really tried to play with the system. That is nice. Okay, seizures. Okay, myoclonus, I think. Very good. So that is a benign sleep myoclonus, which can sometimes persist up to 30 to 40 minutes. And I usually get a call from the NICU when I am on service from the resident or from the fellow saying that Dr. Ramachandran, this child is having continuous seizures. We just loaded with the phenobarbital, and it still continues. I said, is the child sleeping? Yes, wake the baby up. Well, you got the diagnosis. The way you differentiate myoclonus is if it is repetitive, it will be arrhythmic, whereas a clonic movement is usually very rhythmic. Well, let us look at video number 2. Okay, what is the clinical event in video 2? Just type in. Tonic seizure. Okay. More, please. Infantile spasm. Anyone else? Okay, so this is hyperplexia. So this is a condition characterized by defect in glycine, and there is a genetic defect, and the baby during the episode will be fully aware but quite distressed. They usually start with a very exaggerated motor reflex, and they have, even at baseline, increased tone. So this is hyperexplexia, and the EEG during that time will not show an EEG seizure pattern. The treatment is usually clonazepam. Okay, so there are experienced pediatricians, neonatologists, neurologists, and NICU nurses. How good are they in picking up clinical seizures? So this study was again conducted by Dr. Boylan from Ireland. There were 20 videos. There were seizure videos and non-seizure neonatal videos, and each were classified by video EEG as seizure or non-seizure movement. And they recruited healthcare professionals, physicians, as well as nurses, and presented the video with the actual clinical history. Well, and this is the result. So neonatologist with experience of more than 14 years, they picked up nearly 12 correct out of the 20. Then look at the pediatricians. They, with less than 10-year experience, they picked up more than 11. And looked at the nurses, they picked up, NICU nurse picked up 11. So it doesn't matter whether you are a neonatologist or a physician or a nurse, your pickup rate is essentially 50%. So 11 seizures and non-seizure movements, 91 physicians, 46 nurses, and correctly identified events were physicians 10, nurses 10. But if you really look for the correct diagnosis, what is the inter-observer reliability between physicians? The kappa was less than 0.1. So that means some people got some correct, the other physicians got some other correct. So it's not that good. So it is just like flipping a coin and say this is a seizure or not on clinical basis. So this is the famous classification by Volpe, the clinical neonatal seizures are subtle seizures, clonic, tonic, and myoclonic seizures. But this is the latest International League Against Epilepsy proposed classification. Dr. Vinayan, I think all of you know, just told me recently that this is yet to be published, but will be recently published. He is in various committees of the International League Against Epilepsy. So this classification is strictly based on EEG. Only if there is an EEG evidence, the phenomenology will be classified as a seizure. So there will be automatisms, clonic seizures, epileptic spasms, myoclonic seizures. Sequential seizures is, it starts as one type, evolve into different type with the EEG pattern changing over several minutes or seconds, and tonic seizures as well. So this is going to be the latest classification. But well, if you don't have EEG, you need to have some sort of diagnostic accuracy. So this was published in 2007. This was titled for resource-poor countries. The interesting comment about this is that none of the authors were from developing countries. So the paroxysmal movements with a high correlation with electrographic seizures on EEG were only focal clonic seizure, focal tonic seizure. So if you see those movements in a neonate, you're pretty sure that that is going to be an epileptic seizures. But if you have motor automatisms, myoclonus, multifocal clonic movement, it is 50-50. And I don't have to speak to you guys about jitteriness and tremor and sustained myoclonus. Well, if you don't have EEG, maybe some of the centers may have a limited channel EEG. So EEG, there are a lot of electrodes over the scalp. Here you can see 5, you can see 4, but there will be one more, that is a ground. And this is put on the central region. This is put on the baby is facing to the left. So this is the front and this is the back. So this is the biparietal and this is the bicentral. And this is known as an amplitude integrated EEG, where over time there is a Fourier transformation and the amplitude will be plotted against the time. So in seizures, what you see is this: from this baseline, you see a sudden elevation of the base, and this is the typical seizure pattern. And you can see this is almost how many? It started at 9:20, and so almost 1 hour epoch. Whereas if in an EEG, what you see in the screen in real time is like 10 to 15 seconds. But by the bedside, you can see for 1 hour, or some people even put it as 6 hours. I believe Calicut has a few machines. Well, how do you approach a neonate that presents with suspected seizures? The way I approach is it a well baby? Well, the baby is not well. I know that because the baby presented with seizures. But well means otherwise well-looking baby and a sick baby. So a otherwise well-looking baby, it could be a benign neonatal convulsion. It could be a familial pattern or a non-familial pattern. So you can carefully ask the history where in the parents or the grandparents during neonatal period, they had any abnormal movements. And one of the very characteristic feature is they present with a significant tonic seizure, and it affects their diaphragm and the breathing, and the saturation usually drops. So it might appear very dramatic, but over time, the child settles. If you have a very focal cortical malformation, the child could look well. Otherwise, stroke. When I say stroke, a very focal arterial ischemic stroke. And the most common neurological presentation of neonatal stroke is seizure, not weakness. If the baby has focal weakness, most likely that is brachial plexus injury. They don't present with weakness. And some metabolic conditions, when they are mild, when the baby starts feeding, initially they may appear well with the seizure, then subsequently they decompensate. A sick baby, when I say sick baby, I really mean an encephalopathic baby. So it could be, most common cause could be hypoxic ischemic injury, cerebrovascular injury like hemorrhagic or ischemic stroke, infection, metabolic, and all the weird and wonderful genetic conditions, which day by day you are getting hundreds of new mutations. So how do you investigate? I don't have a specific algorithm. It really depends upon the child and the context. But essentially, everybody does the first line, that the extended lights and the glucose. And in neonates, the suspicion for meningitis should be very high. And the threshold for doing a lumbar puncture should be very, very low. It can rule out infection, and if the glucose level is very low when compared to the simultaneous blood glucose, it could be glucose transporter deficiency. It is not very uncommon. Even in our center, collectively, we have about 15 cases which we are following, because lifelong they need ketogenic diet. So that is something that you should never miss. It could be a non-ketotic hyperglycemia. If the child is encephalopathic with very recurrent hiccups, well, you got the diagnosis. That is non-ketotic hyperglycemia. And it has a very characteristic MRI picture like maple syrup urine disease, neurotransmitter disease. All these things you can check in the CSF. Imaging, if the child is sick or if the seizure is focal, in our practice, we get MRI brain in almost all the babies, unless it is like a mild electrolyte abnormality I don't say mild, but very, very brief correctable electrolyte abnormality. Otherwise, all of them will get an MRI brain. Toxicology, plasma amino acid, urine organic acid, all the extended investigation depends upon if the seizures continue and if the baby deteriorates. You have to have a stepwise approach. And rare disorders, this is, well, in Canada, this is a typical OSCE question. In pediatric neurology, if the child doesn't have a compelling history of HIE, if the MRI is not consistent with HIE, and the patient has no other explanation for seizures, and if the seizures continue, we investigate for these conditions, and we empirically start on high dose pyridoxine. You can do creatine deficiency by looking at the MRS of the MRI, a male Rett syndrome, NCL, molybdenum cofactor and sulfite oxidase deficiency, characteristic MRI pattern, neurotransmitter deficiency, and biotin responsive seizures. So the genetic test, what we do is, if the conditions which I alluded to a few seconds back are met, we do a chromosome microarray. It will take several weeks to get the result, and if the condition really warrants, we generally go for whole exome sequencing. The question is, why are we doing all this? Does it really matter much? The baby seizure is just a reflection of the underlying injury. So treating and chasing the seizure, is it really that important? Well, there is an argument on both sides to begin with. Brain injury can cause a neurological disability and epilepsy. We know that. And brain injury can also cause seizures. But it is now proven beyond doubt that the seizures can add to the neurological disability. So what we are trying to do is at least tackle one modifiable factor. For that, we need to understand what is the seizure burden. Let me explain. Suppose a neonate over a period of 24 hours in your ICU developed 5 seizures, each lasting 5 minutes. You have another neonate who developed 100 seizures, each lasting 10 seconds. So the number of seizures in one is 5, another one is 100. So if you go by the number, the child with 100 seizure, oh my God, 100 seizures per day, that is terrible. But if you really look at the seizure burden, 100 into 10 seconds is only 1000 seconds. Whereas 5 seizures, 5 minutes each, is 25, and 25 into 60, that is much more than the 100 seizure. So for the brain, the burden and the impact is much more with the seizure burden. So what we really need to chase is the seizure burden, not necessarily the number of seizures. So this was a study from Dr. Stephen Miller, who is the current head of pediatric neurology at the Hospital for Sick Children in Toronto, where I was trained. So he studied 90-term neonates. 33 had seizures and 57 had no seizures. So he devised a very smart methodology. He scored seizures and had a score for resuscitation, and had a score for neonatal acute physiology to account for all the blood pressure and the temperature, heart rate, and there is an MRI severity score. So when he accounted for all the injury factors, seizure was an independent risk factor for long-term impairment. And he also looked at the MRS, is magnetic resonance spectroscopy. So this is a basal ganglia. In group with no seizure, you can see that the N-acetyl aspartate peak, that is a reflection of the neuronal density. No seizure, it is high. Whereas in seizure group, that peak is low, and it also started showing the lactate peak. In the intravascular boundary zone, not only in the basal ganglia, again you can see the N-acetyl aspartate peak is almost normal in no seizure, but it is substantially reduced in the seizure group. So seizures independently affect the prognosis as well. And this was from the same group from San Francisco, because he did his neonatal neurology training there. They did a long-term follow-up, and the findings were replicated on long-term follow-up as well, that seizures were an independent predictor for full-scale IQ at age of 4. So the treatment. Well, before I embark on the pharmacological treatment, a word about therapeutic hypothermia, which I think is universally practiced in all the major neonatal centers. So in this cohort, you can see this is a group with therapeutic hypothermia. and this is no therapeutic hypothermia. And if you really look at the seizure burden, it is significantly lower in the group that had therapeutic hypothermia, and it was high in the group that did not have therapeutic hypothermia. So therapeutic hypothermia does have a protective effect on the brain in terms of generating seizure. Well, the treatment on the left side, you can see the acute management modalities: phenobarbital, phenytoin, lorazepam, diazepam. I don't see that used much. Midazolam, and a new guy, I cannot say new guy, but relatively new, levetiracetam, is also in the acute management. So the question is, what is the first line anti-seizure medication to treat neonatal seizures? Please just type in. So Paul EV / Rajesh R100, and then type in your answer. Well, any more? There is only one answer. Okay, the message is clear. Okay, very good. I'm glad you didn't say levetiracetam. So what is the evidence behind using phenobarbital and phenytoin? So this was a landmark study by Painter Aor in 1999. Well, they enrolled 59 neonates and was randomly assigned to phenobarbital 30. So seizure control was achieved in 43%. So in those, in phenytoin, 45%. Well, subsequently, in the phenobarbital failed group, they gave phenytoin, and they got an additional 13%. That means if you give phenobarbital followed by phenytoin, you get about 56% control of seizure. Whereas if the phenytoin fails, phenobarbital, an additional 17%. So that comes to around 62%. So it is more or less same. So this is the evidence behind using phenobarbital. Then people may wonder why not phenytoin, and why phenobarbital? The reason is phenytoin's half-life in a newborn is very, very short, and you may have to give multiple doses. And if you extravasate phenytoin, I think you are going to get tissue necrosis. So phenobarbital is better in that sense. And once you give 1 or 2 doses of phenobarbital, you are going to get a sustained level for at least 1 to 2 days, sometimes longer. Well, this is a landmark study which was published in May of 2020. So that is just 6 weeks back. So this is a head-to-head comparison between levetiracetam versus phenobarbital in neonatal seizures. Because over the last 10 years or so, there is plenty of literature available on the use of levetiracetam in neonatal seizures, and I understand there will be a lot of MD theses on this. And it was mentioned that the success was huge. But let us see what the randomized prospective control trial showed. So this was a multi-center, randomized, blinded, controlled dose escalation safety study, which was compared with phenobarbital as a first-line treatment of neonatal seizures, not funded by any pharma, funded by the FDA. So HIE and at-risk neonates were prospectively enrolled, or if there is a suspicion of clinical seizures, and the subjects consented and continuous EEG was initiated. So EEG, continuous EEG, not just one EEG, is a continuous video EEG monitoring was part of the recruitment strategy and the treatment strategy. When electrographic seizures were detected, subjects were randomly assigned, and you can see the time points. So on the left side, you can see the levetiracetam, a load of 40 milligram per kg, phenobarbital 20, and at time 30, if they failed, an additional 20 levetiracetam, additional 20 for phenobarbital, and at time 60, an additional dose of phenobarbital. So at 60 point, they switch over to the other drug. And this was the intention to treat analysis. You can see 24-hour seizure cessation rate was 80% in the phenobarbital, our good old phenobarbital, was only 28 in levetiracetam at a dose of 40 to 60 milligram. And the subsequent secondary analysis was also favoring levetiracetam. So one criticism about this study was, well, then what about the 1999 study about Painter, who described only 47% response to phenobarbital? The authors comment that now therapeutic cooling is the standard of practice. Probably it improves the therapeutic efficacy of phenobarbital. And since this is an EEG-based study, there is more accurate description of the seizures and the seizure frequency and the seizure number, because the 1999 study did not use continuous EEG. If you guys are really interested, especially the postgraduate students, I encourage you to go through this WHO manual on the guideline of neonatal seizures. The practical consideration people ask me are, well, we don't have EEG, we don't have a neurologist, we don't have an MRI. When we don't have an EEG, why are you talking about continuous EEG? I think these are very practical, important questions, but unfortunately, I don't think I am the most qualified person to answer those questions, because for so long, my practice has been different. What I can say is, if the child is at a very high risk of having seizures, if they have focal tonic or focal clonic seizures, you are pretty sure that that is a neonatal seizure. By the way, if you happen to do an EEG and you capture a clinical event and you correlate that is a clinical seizure, maybe for subsequent clinical follow-up, you can use that clinical movement. I encourage all services to have their own internal policy, because when the resources are poor, everybody acts in good faith and with the good intention. You can have a policy, but I don't have much further advice or suggestions as to what to do when you don't have these facilities. So I have to thank my comprehensive pediatric epilepsy team, which is a program within the overall pediatric neurology service at McMaster Children's Hospital. So my epilepsy team has epileptologists. I have my colleague epileptologist. We are getting one more in a few months. We have a nurse practitioner, dietitian for ketogenic diet, EEG technologist, social worker, neuropsychologist, and psychometrist. And I thank him from the bottom of my heart. They are the best team. And I thank my family, my wife and 2 kids. And people may wonder what I do when I have time. And this is my latest passion, and this is my latest light music. Encourage you to watch and listen, and this is what I do. And thank you all. I was told that this should be a 30 minutes presentation. I am sorry if I exceeded the time. I am happy to answer questions if there are any.
Thank you, Dr. Rajesh. It was a really wonderful session, and we are all impressed by the clarity of your thoughts. You are very, very clear in your points. And regarding, I think there will be a lot of doubts. One point I want to ask is, how once you recognize a seizure in a newborn, how long will you continue anticonvulsants?
Good question. So that depends upon the context. So in my experience, if the child has seizures, by the time the neurology is not often consulted because our neonatologists, neonatologists are neonatal intensivists. So they deal with the acute seizures. When they call us is the first line, phenobarbital doesn't work, and then they call. So we don't get involved in all the easily managed cases when phenobarbital controls a seizure, because they usually go by their amplitude integrated EEG and they just do an EEG for prognostication. Very rarely they ask for a continuous EEG monitoring if the seizures are easily controlled. So as a pediatric neurologist on service, my starting point is the patient has already received 40 milligram per kg of phenobarbital. So the question I ask myself is, are there really seizures? So if I'm convinced that they are seizures, what is the underlying etiology? Is it an immediately correctable etiology, or is it an etiology that is likely to leave some permanent damage, or is it an epilepsy syndrome? So I haven't touched the epilepsy syndrome like the fancy terms like Ohtahara syndrome, early infantile myoclonic epilepsy. So that is a separate topic. So for the time being, I am restricting my thought process on this acute symptomatic seizures, neonatal seizures. If it is an HIE, there is no universal guideline. But a study was conducted among the pediatric neurologists in North America about 10 years back to understand their practice of phenobarbital at the time of discharge. The result was highly variable. Some said we will stop on the 4th day, and some said we will continue as long as 6 months. So there is no universal guideline, but I am happy to say what I do. In 90% of cases, phenobarbital will be stopped before the child goes home from the NICU. Because in HIE, the maximum seizure is within the first 4 days. And after 4 days, the seizures in majority will decrease. A few patients will have lingering seizures. In those, I might continue for up to 1 to 3 months, but never beyond that. But if things change and the child evolves into infantile spasm, some of them do, then the therapy will be changed. The bottom line is it is up to the neurologist or the pediatrician, and there is no guideline. But what I would say is treating HIE with the phenobarbital is not going to change the percentage of future development of epilepsy. If it is going to develop, it is going to develop. But probably you can protect the brain in the interim.
You are very, very clear in your point. But that is what exactly we are also doing as part of our PREVENT trial. If the child is seizure-free, we will stop the drug, observe the child for next 3-4 days, and we will send back without any anticonvulsant. And again, if the child is started on one more drug, we will be stopping the first drug. So the child won't be on multiple anticonvulsants. And as you rightly mentioned, the anticonvulsant is not going to change the future seizure episodes. I invite any other questions from the audience.
Mohandas, Purushothaman sir is there.
Purushothaman sir. Purushothaman sir.
Yeah, Kelkando. About the pyridoxal phosphate and biotin, you said, Rajesh. What's your experience, the response to pyridoxal phosphate, whether neonatal seizures occur due to that responding type in the newborn period, and about the biotin sensitive?
Yeah, so in my life, I have never seen a biotin responsive seizures, but somehow in certain intractable cases, very religiously, I put the patient on biotin because the test, it will take some time, and none of them had any typical skin lesions either. Then regarding pyridoxine versus pyridoxal phosphate, pyridoxal phosphate will work for both pyridoxine dependency as well as pyridoxal phosphate deficiency because the genetics is different, but downstream it is the pyridoxal phosphate that matters. but in pyridoxal phosphate deficiency, pyridoxine will not control the seizures. I have experience with only one patient with the pyridoxal phosphate at McMaster Hospital that was genetically proven, but we were much late in initiating pyridoxal phosphate because the genetic test came very late. The patient was only on pyridoxine. The child is significantly delayed. Now, regarding starting pyridoxal, if there is not a convincing history of hypoxic ischemic encephalopathy, MRI not consistent with that, and if the seizures persist, then we empirically start them on pyridoxine, 15 milligram per kilogram body weight.
Thank you, Rajesh. That is a wonderful presentation. Very clear, lot of important messages. Thank you.
It's lovely to see you after so long.
Regarding this biotin dependent seizures, we have two mutation proven cases, and among that one baby had alopecia also, and with biotin they are seizure free, and we have mutation proven cases of pyridoxine dependent seizures also, and 3-4 cases of molybdenum cofactor deficiency. Okay.
So the molybdenum cofactor deficiency is a spectacular disease because the MRI is quite impressive. So the initial few days, the MRI will show all the cortical areas very swollen, and within about 2 to 3 weeks, you start seeing this cyst forming, multiple cysts.
Mohandas, there's a question in the chat box. Role and policy of tapering anticonvulsant in neonatal seizure. Role and policy of tapering anticonvulsant in neonatal seizure. A question from audience.
Okay, so I thought we already answered that. If the question is really pertains to, suppose the child is on 5 milligram per kilogram body weight of phenobarbital, will you taper it to 3, 4? Is that the question? By tapering, or is just stopping?
Actually, the question is from Dr. Kasim. Kasim, you can ask it through the microphone.
Yes. What is the policy of
Kasim, parno.
tapering of anticonvulsants? Is there any policy of how fast you should taper and all?
Okay, so let me answer the question as I understand it. So the tapering, it has got two meanings. The tapering, it is when do you stop? So that is already addressed based on Dr. Mohandas' question. If you are really tapering, if the patient is on a very short course, few days, and the 90% of my patients, they are on that, I just stop it. The reason is phenobarbital has got a very long half-life. So even if you stop and if you do the blood level the next day, the level is going to be high. So there is actually no reason for tapering phenobarbital. However, in my practice, if I have used phenobarbital for more than 1 month, I usually do a very gradual taper over 1 to 2 weeks. If it is more than 6 months, the tapering will be over 1 month. And in some babies in whom phenobarbital, I doubt whether I have any babies on phenobarbital, maybe 1 or 2. For 1 or 2 years, the tapering has to be for over 6 months. Well, I have to say that you guys are seeing more cases of the genetic and metabolic conditions because of the huge number of population you guys serve. Whereas in North America, we have so many centers, but the number of patients we see are so limited. So maybe 20 years back when I left, or 16 years back when I left India, I could say, oh my God, things are so different. But now, properly, India is overtaking in everything in medical because everything is available and there's a huge patient population. So the collective experience, just clinical plus the investigation, is very, very rich in India now.
Mohandas, Dr. Rajesh, I am asking a question from a different area. I think the ketogenic diet is an area of interest for you. So what is your experience in pediatric practice, pediatric neurology or pediatric epilepsy?
For ketogenic diet?
Ketogenic diet.
Yeah,
Ketogenic
so
diet.
my interest is, I have a research interest. I have a funded multi-year grant for studying the effect of ketogenic diet. So this is how it works. So a child present with first onset afebrile seizure and had second seizure, you make a diagnosis of epilepsy. We are forgetting about all the benign rolandic and the benign epilepsies, the typical epilepsy. If the first drug usually works in 55% of people to control the seizure. If the first drug fails to control the seizures, if you add the second appropriate drug, the success is an additional 11%. So first drug fails, if you add the second drug, two drugs together, the combined seizure freedom is less than 65%. So if two appropriate drugs fail, and if you add a third drug, the chance of seizure freedom is less than 3%. So if you have three drugs that failed, you are getting around 2/3 of patients. That means you can go for all the wonderful new drugs, but at the end of the day, you will be left with about 25% of pediatric patients who do not respond to medication. So among that 25% of patients, there are certain groups of patients that present with a myoclonic component. Say, for example, a Dravet syndrome or a Lennox-Gastaut syndrome, or a child with non-syndromic but predominant myoclonic seizures or a generalized seizure. Ketogenic diet will control seizure in about 15%. Well, I will take 15% compared to the 3% for the third drug, and it controls seizure by 50% in 50% of population. So we have several patients who became seizure-free on ketogenic diet, but not all patients do. But I encourage all the pediatric centers to develop a ketogenic diet service. I think it will be quite rewarding. But I have to say, being an Indian and who loves my chapati, bread, and rice, it is going to be tough because you have to cut down on carbohydrate very heavily and substitute that with fat. And if you are a vegetarian, an experienced dietitian can do the trick, but it could be a challenge. But in a selected group of patients, it will be quite rewarding.
Thank you.
Ajit, any comments? Ajit?
Yeah, Dr. Rajesh, it was a very excellent talk, very clear, crisp and clear, and we thank you for taking this time out, especially the late night, and we have this is co-hosted by IAP, Indian Academy of Pediatrics, and Dr. Ashraf is our president of IAP Calicut branch, and we have Nihas. Dr. Ashraf, can you? This is the first of our masterclass series, and I'm very thankful to IAP Calicut for arranging this. And I think Dr. Ashraf, can you your comments on that?
So before that, thank you IAP Calicut and Medical College Department of Pediatrics, and I have quite fond memories of Calicut. I remember working with Ashraf, Mohandas, Ajit. I can recognize Geeta, Jay Krishnan, and I still remember the drama around starting a pediatric neurology clinic at your site, and it was fun. And I hope now there is a clinic. And now, then I was quite fortunate to
has changed a lot. Now the situation has changed a lot.
Nice. So I was quite fortunate to work with Dr. Girija, who taught me a lot. And unlike many other HODs those days, she gave me full charge of the ward for 1 day a week. I was able to do independent rounds. So I am always thankful to Dr. Girija for my training and experience at Calicut.
Nihas?
Dr. Ajit, any other comments from the floor, from the audience? Any other doubts? If there is no, we will move on to vote of thanks. I think Nihas just left the group because he has to go to his hospital. He's ended.
Okay, Ashrafana Varnadi.
Then thank you, Dr. Rajesh, for that excellent talk. It is very nice to see you and hear you on Zoom after a long period. I think you left Calicut in 2002 or 3. Is it 2002?
2004 June.
4. This is 2004. Then the talk contains many take-home messages. It covered entirely from the basics of the neonatal seizure to the recent advances. But I think the most important message you conveyed is the teamwork in the field of neonatal epilepsy. It should not be a doctor-centric. It should be a teamwork. Includes many specialists, staff nurse, dietitian, and a special thanks to you for mentioning the importance of the ketogenic diet. We often forget that, or not practicing that, the dietary management, even though is always concerned about the growth and the importance of the nutrition in many chronic diseases or disorders. So, thank you. Nihas is there. Nihas is our vibrant secretary of the Calicut IAP. Actually, this meeting is attended by the faculty and PGs from the Department of Pediatrics, not only from the Department of Pediatrics, Kozhikode, but many other medical colleges in Kerala, including the persons from the outside the Kerala. By looking on the names, there are some North Indian names also in the participants. So, thank you, Dr. Rajesh. Before that, over to Nihas. Nihas is our secretary. He is also a neonatologist.
Thank you, Rajesh sir, for that nice and crisp presentation on neonatal seizures. And I'd like to thank Department of Pediatrics, Ajit sir and Mohandas sir and Addtl sir for taking such an initiative along with IAP Kozhikode to start a master class in the morning of every Wednesday morning, and that too from speakers outside India. So thank you, Ajit sir. Thank you, Mohandas sir, and all the PGs and my colleagues who attended this meeting. Thank you all for coming. And also I'd like to thank Nabil especially for taking the pains to come early morning there and hosting this meeting. Thank you, Nabil, for helping us out. And we have one more meeting today, today evening at 8 o'clock. So I invite all of you for that also. The session is by Dr. C.K. Sachidharan. Thank you all. Thank you, Rajesh sir, again for that nice talk. And
thank you, Dr. Rajesh, and good night for you, and a pleasant day to all others.
Thank you so much. It is almost 12 o'clock. Let me go to bed. Bye-bye. Take care.
Happy Doctors' Day to all.
And July 1st is Canada Day too.
Yeah. Okay.
Okay. Bye. Take
care.
We will have a TL. He's in Mohandas.
The Rajesh poi.
Okay, bye.
Okay, thank you.
Nabil, meeting ended though, Nabil.
Thank you, Dr. Ajit and Mohandas and the department colleagues for including IAP also in this program.
Nabil കേൾക്കണ്ടോ?
Meeting
meeting end ചെയ്തോ?